Thank you for joining the National Headache Foundation's Sinus and Migraine webinar. Today we're joined with Christina Treppendahl, who is a board-certified nurse family practitioner, and she runs the clinic, the Headache Center in Ridgeland, Mississippi. Christina, thank you for joining us today.
Thank you. You ready for me to begin?
Sure, go ahead.
Okay. Well, when y'all asked me to talk tonight, you gave me the option to choose anything I wanted to talk about. So I decided to choose to talk about sinus headache versus migraine. And I have to answer this question every day. So you might be asking why I chose this topic. Well, I believe that accurate diagnosis leads to optimal outcome and treatment. So I'm going to expand on that. Let me just figure out how to work this. Okay, these are my disclosures. A little bit about me. I used to be a neonatal nurse practitioner for 10 years in my first career. That means I used to take care of only sick and premature infants in the neonatal intensive care unit. And then I went back to school and got a family nurse practitioner degree. And I've been basically treating headache ever since. I did a small rotation. I worked in the emergency department for about 6 months as soon as I got out of my family nurse practitioner school. But I really love headache. I've been treating headache since 2010, and I've owned my own headache center since 2013. And anybody who knows me in Mississippi knows that I have a passion for treating headaches. And we have the only headache center that is open presently in Mississippi. So we treat patients from all over Mississippi. The goal of the lecture today is that any patient or any clinician would be able to distinguish the difference between sinus disease and migraine headache based on the criteria set forth by the International Classification of Headache Disorders and the guidelines by the American Academy of Otolaryngology. And also that more cases of migraine would be diagnosed instead of sinus headache, which in my opinion, sinus headache is a misnomer. And hopefully you'll agree with me by the end of this presentation. And also I hope that more migraine patients, or migraineurs as we call them, would get more prevention and abortive treatment plans that present with migraine and sinus symptoms. Okay, and I see this patient every day in my clinic. I run a headache center. We treat only headaches there. But in the primary care clinic, just the family physician, the family nurse practitioner, they see this every day as well. They see Jane. She comes in and she says, I have a sinus headache. She says, I need an antibiotic. Can you help me, please? She's had this before. Antibiotics, she took them for a few days, and they worked in the past, and she's got the pressure. She gets these headaches or this pain whenever the weather changes. The weather changes every other day in Mississippi. She gets nasal drainage. She gets lacrimation, which means watery drainage, tearing of her eyes. She gets sinus pressure, facial pain. It can also be called a headache in that nasal area. She gets nasal congestion, and she also has allergies. But we see patients like this every single day. There was a phenomenal study that came out in 2001 in the Journal of Headache that was put out by Richard Lipton and colleagues called the American Migraine Study 2. And based on the study, they estimated that 28 million people with headache met the International Headache Society criteria for migraine. But what was interesting is that of those people that met the criteria for migraine, only about half had been diagnosed with migraine. And the analysis of those who were underdiagnosed revealed that 42% considered their headaches to be sinus headache. And further analysis revealed that these sinus headache sufferers met the criteria for the International Headache Society criteria for migraine. And I just want to tell you that when you're doing a PowerPoint that says IHS, the autocorrect wants to change it to his all the time. So you're going to see some typos in here. And so we're going to look at who who sets the criteria for classification of headache, and that is defined by the International Headache Society. The International Headache Society came together in 1988 and came up with the first international classification of headache disorders that came out in 1998. The second edition came out in 2004, and the first version, the beta version, came out for the third edition in 2013, and they're supposed to finish that version in 2018. And this is published in the journal called Cephalalgia. And migraine is considered a primary headache disorder. A primary headache indicates that the headache is the primary problem, meaning that there's no secondary cause, such as a brain tumor. With a primary headache, there's no laboratory markers or positive signs from an imaging test, meaning like your MRI is negative or normal. The diagnosis is best made by a careful history and physical exam. So this is the International Classification of Headache Disorder criteria for migraine, and I'm just going to briefly go over it. Basically, it's a headache that lasts anywhere from 4 hours to 72 hours, and it has about 3 of the following: unilateral location, meaning it's on one side or the other, pulsating, moderate to severe pain. Nobody complains usually of a mild headache. Activity bothers the headache, either makes it worse or people avoid routine activity, makes them have decreased production at work, and they can have nausea or sensitivity to light or noise. Now, you don't have to have all 6 of these to have migraine. You just have to have a few of these to have the diagnosis of migraine. And then migraine with typical aura includes some of those symptoms from the previous page, plus visual, sensory, and or speech symptoms, and they are totally reversible, but no motor, brainstem, or retinal symptoms. I'm not going to go into detail about that. That's another topic altogether, migraine with aura. Now, headache attributed to sinus disease would be a secondary headache. And let me tell you what the International Classification of Headache Disorders calls secondary headaches. Secondary headaches are attributed to another condition, such as a brain tumor, trauma, infection, or vascular disorder. There is clinical evidence, laboratory markers, or positive signs from imaging tests that should be present, okay? Now, I've got 11.5 in red to show that this is where the International Headache Society has put sinus disease. But they threw it this year into the appendix, or in 2013 into the appendix, meaning that there's insufficient evidence. And if you look at the bottom, they want to basically eliminate this diagnosis or certain diagnoses that were in the second edition. The appendix means that they don't really think that there's enough evidence for these things to be in the ICHD criteria. That's why the beta version is not finished. Very technical. Okay, so basically this gets kind of hairy, so I'm going to just cut to the chase on this. Basically, they said that you have to have clinical nasal endoscopy or an MRI or CT evidence of an inflammatory process in the nasal cavity. You have to have a headache in direct relationship with an intranasal lesion. It has to either improve or get worse with the improvement or worsening of the nasal lesion. The headache does. And they put examples at the bottom are concha bullosa and nasal septal spur. Okay, then I went and I looked at the American Academy of Otolaryngology. What did they say about sinusitis? And by the way, nowhere in here do they say anything about fever like they did in the past, okay? They said acute rhinosinusitis has to have purulent nasal drainage. Purulent is yellow or green, creamy drainage. And if you want to look at this, go look up sinusitis and endoscopy. It's kind of gross. I should have put a slide here on that. But it looks like yellow cottage cheese in the nose. It's really disgusting. Nasal obstruction or congestion and facial pain, pressure, fullness. Viral sinusitis, just think of that as less than 10 days. Bacterial sinusitis, think of that as more than 10 days. and chronic sinusitis 12 weeks or longer. But the key thing that distinguishes this from what we're going to see with migraine is migraine can have drainage, but it's watery drainage. Sinusitis has purulent drainage or mucopurulent drainage, and also it lasts a lot longer. Okay, and when I'm talking about lasts a lot longer, migraine lasts 4 to 72 hours, and it's usually episodic. Okay, it comes and it goes. It comes and it goes. It comes and it goes. Whereas an infection, it lasts days. Okay, I'm going to talk a little bit about migraine pathophysiology. In the past, we used to think that migraine was attributed to a vascular disorder. They taught in medical school, in medical training, that migraine, that there was a vascular etiology, that there was an initial period of vasoconstriction in the arterioles of the blood vessels in the brain, followed by vasodilation. They said that the vasoconstriction was the cause of the aura phase, and that the vasodilation was the cause of the throbbing. But they know that that's not true anymore. They really say now that migraine is a brainstem dysfunction and a trigeminal nerve dysfunction, and that activation of the trigeminal nerve, the fifth cranial nerve, as you can see on this slide, the slide's kind of blurry, but the trigeminal nerve, tri meaning three nerves, the top nerve where your eye is the ophthalmic branch, where your nose is, and this is very important, is the maxillary branch, and the bottom nerve is the mandibular branch. These are the three nerves of the trigeminal nerve, the fifth cranial nerve. These can cause facial pain and pressure in the forehead, the cheekbone, and the jaw areas. And involvement of the parasympathetic nervous system via the superior salivatory nucleus and the brainstem activation can explain the nasal congestion and watery, itchy eyes. And there was a study published in Cephalalgia, again in 2002 by Barbanti, that they wanted to look at the autonomic symptoms in migraine. Okay, so they interviewed 177 consecutive migraine patients in a headache clinic. So the key is they weren't picking and choosing. They just looked at 177 consecutive patients, and they asked them about, or they looked at their charts about autonomic symptoms. The lacrimation is crying or eye watering, eye redness, ptosis is eyelid drooping, eyelid edema is swelling, nasal congestion, and rhinorrhea, which is watery drainage from the nose. 45% of the patients reported at least one autonomic symptom during the migraine. 45% had both nasal and ocular symptoms. 21% had only nasal symptoms, and 34% had only ocular symptoms. So that's quite impressive percentage of migraineurs with autonomic symptoms. Okay, this is a really busy slide. They teach you in slide making school that you should never have a busy slide, but there's a lot of important information on here. Katie and Schreiber in 2002 did a pilot study on 47 patients in 2001. I'm sorry, it's 2002 or 2001. I got my dates wrong. They did a pilot study on self-diagnosed sinus headache patients. And the exclusion criteria was that you could not have a previous diagnosis of migraine, you could not have a fever, you could not have a positive sinus CT, you could not have purulent nasal discharge, and you could not have headache on more than 15 days per month. And 46 out of 47 of those patients, which is 98%, experienced sufficient enough symptoms to achieve a diagnosis of the International Headache Society, that's where it auto-corrected for me, of migraine with or without or probable migraine. So 46 out of 47 patients who thought they had sinus headache actually fulfilled the criteria for migraine. The typical migraine symptoms were moderate to severe pain. 98% of these people had moderate to severe pain. Most of them had nausea, sensitivity to light, noise, one-sided head pain, unilateral head pain, pulsating pain, pain worsened by activity, and some had vomiting. I have a lot of patients who come to me who think they don't have migraine because they don't vomit. A lot of patients have nausea, but not everybody vomits with migraine. 89% were found to be substantially or severely affected by the impact of their headaches, as measured by the HIT-6 or the headache impact test. And in addition to their migrainous symptoms, those typical features that we see on the left that are part of the diagnostic criteria from the International Headache Society, we see the autonomic features of 74% reported nasal stuffiness, 60% reported rhinorrhea, watery discharge from the nose, and 45% reported weather-associated headaches. And then several of the patients were asked to treat 2 of their headache attacks with triptans. 71 headaches were treated. 12 were treated with mild pain when the headache attack was mild. Okay, you're going to get different outcomes if you treat when the headache pain is mild versus when it's moderate to severe. 59 treated when the headache was moderate to severe. And these outcomes were similar to the trials of triptans on migraine patients. Now, these are sinus headache patients. 42% of the mild headache patients were pain-free within 2 hours. 66% of the moderate to severe pain patients reported mild to no pain within 2 hours. And 34% of the moderate to severe pain patients were reporting pain-free within 2 hours. So the point of this is people who thought that they had sinus headache for several years, and my sister is one of these patients. She had been treating sinus headache with nasal decongestants for 19 years before I gave her a triptan, and she responded well to the triptan and realized that she had migraine. People are treating themselves with over-the-counter nasal decongestants, etc., sinus and over-the-counter things that are not really helping. They're also not getting, if they realize that they have migraine later on and get the correct diagnosis, then they can get prevention. And if you can get the correct prevention, then you don't have to be chasing your headaches with attack medicines all the time, and you can get the appropriate attack medicines. Okay, this is my second to last study from Schreiber, Hutchinson, and Webster in 2004. They looked at both self-diagnosed or self-reported and physician-diagnosed sinus headache. And the results are very similar, but the first one was a pilot study, and this one was a very large study of almost 3,000 patients. Inclusion criteria, a 6-month history of at least 6 attacks or 6 diagnosed sinus headaches, and then the exclusion criteria is you could never have been diagnosed with migraine and never had a triptan before. That's the inclusion criteria. Exclusion was that you could not have evidence of acute sinusitis. And basically, if you look at the top right over there, 88% of these sinus headaches were diagnosed with migraine-like headaches based on their symptoms through the International Headache Society criteria. And if you look at the symptoms, they're almost exactly the same as the previous slide. They had the symptoms similar to the diagnostic criteria that I showed you from the International Classification of Headache Disorders, and then they also have the sinus symptoms of sinus pressure, sinus pain, nasal congestion, rhinorrhea, watery eyes, and itchy nose. I have a patient who takes the Relpax almost every day for a migraine that's only in her nose. Okay, and I just want to leave you with this. I copied this straight from this article, Migraine Headache Misconceptions, Barriers to Effective Care from Wenzel, Dorch, and Roger Cady. This is an article. It's a great article. It's very long, but they were writing this article for pharmacists, and I'm just going to read it to you. It's very poignant. A recent headache clinic-based study of 24 patients with self-diagnosed or physician-diagnosed sinus headache found that 90% fulfilled International Headache Society criteria for migraine. Notably, only 4 patients had evidence of active sinus infection. 2/3 of these patients were completely dissatisfied with their therapy, a not surprising statistic given these patients' incorrect diagnosis. This is important. The notion of recurrent incapacitating tension or sinus headache affecting large numbers of individuals is not supported by published evidence or clinical experience. Furthermore, improper diagnosis leads to inappropriate drug therapy, increased risk of adverse effects, as well as patient and clinician frustration from failed therapy. To avoid these pitfalls, we propose pharmacists adopt a philosophy that any patient presenting with episodic, debilitating headaches be considered to have migraine until and unless appropriate evaluation proves otherwise. Simply put, debilitating headache, think migraine. I've had several patients, but I have one in particular. He's a man. He was one of my first patients who came to my new clinic, and he'd been treating his daily headaches for 19 years. He's about 37 right now with, I don't know, FNP-BC and decongestants. And he's been on Topamax, a prevention medicine, and weather was a huge trigger for him, but he still had to take daily medicines. And he came to my clinic, and he has Imitrex injections for bad headaches, and he has some oral triptans. But a tornado came through his town recently, and he said the tornado came through, and he still did not get a migraine. He didn't even get the slightest headache, and he has like 6 children and a lot of stress, and he can go now like 6 weeks without having to take any medicine whatsoever except for his prevention for his headaches. So he's really good patient to have. And then so I hope all of you know that the next time you think about sinus headache, you know what to look for. These. Anyway, these are my references, and these are some really good resources that I look at every single day. I go here for great articles, and I also, the one at the bottom is really good if you have children with migraine or a family dealing with children with migraine. And also, I put stuff like this up on my website. Also, another good video to watch about sinus headache and migraine, I just put it up on my Facebook page. It's from Roger Katie's clinic, and it's about migraine pathophysiology, and it's up on my Facebook page, and that's my Facebook page right there, facebook.com, the Headache Center, and it's a great video that shows the pathophysiology of migraine and why your sinuses might feel inflamed because of all the blood vessels that are being triggered in the autonomic nervous system. But thank you, and if you want to open up to questions right now, I'm available.
Christina, thank you for your presentation. This was great information. I'm sure that everybody needed a refresher, or that you've answered all of their questions this evening. So I'd like to thank everyone else for joining us. Oh, yes, I'm sorry. So 2 questions. Well, one, the PowerPoint presentation will be available. We're going to go ahead and get everything edited and upload it to our website. So I thank you all for joining us, and we'll keep you posted on the next webinar. Christina, thanks again.